Thank you for joining iMeet. This meeting is now being recorded.
Good evening, everyone. I'm Ara Christian coming to you from Loma Linda University, and on behalf of my co-moderator, Dr. David Shaw from Harvard-UCLA, we are extremely excited to welcome you to another highly anticipated edition of our AABIP webinar series. Today we have an extremely relevant presentation for you. But before the formal introduction of our topic and speakers, I'd like to review a few housekeeping matters. First, everyone please note that this webinar will be recorded. It, along with previous and future webinars, can be viewed on the AABIP website, and this can be found under the Education Training tab on the front page of the AABIP website. Second, we ask that all participants mute their phones during the course of the webinar to minimize the background noise and optimize the overall listening experience for the audience. Alternatively, you can use the volume control icon at the bottom right of your iMeet window. Now, to ask questions or communicate with the group during the webinar, please type them into the chat box. This can be accessed by clicking on the thought bubble icon located in the bottom left of the iMeet window. Now, we leave it up to the presenter to answer the questions as they appear during the talk, but we will keep track of the questions as they come up and address them towards the end of the hour in a formal Q&A period. So please feel free to type in your questions at any time through the webinar. Now, also on the bottom left is a projector icon. This allows the audience to toggle between the presenter's slides and any videos. I do not think we have videos in our talk today. And finally, a couple important disclaimers. The AABIP does not endorse any specific technologies or products. Also, the content and views expressed within the webinar represent the opinions of the speaker and do not necessarily reflect those of the AABIP. So without further delay, I'd like to turn things over to Dr. Shaw for our formal introductions today.
Thank you, Ara. So today, as you can see, our topic is After the EBUS Needle, Optimizing Specimen Collection and Processing. And we're really pleased to have with us today two different speakers, both from MD Anderson Cancer Center in Houston, Texas. The first is John Stewart, who is a nationally recognized cytopathologist. And because we don't work independently or in silos, we also have on the panel Dr. Roberto Casal to provide insight from the pulmonary side. But again, the primary thrust of today's talk will be looking at the pathology aspects of our EBUS TBNAs. So without any further ado, I want to thank both Roberto and John for joining us and turn the time over to them.
Thank you. Thank you. So let's get started. There's an awful lot of slides to get through, and some of these I'm going to go through very quickly, but my understanding is that you will have access to this talk in a recorded format. So if there's anything I go through too fast, you'll be able to go back and look at and study. Let's see, next. So I'd like to pose this question: what is the role of the bronchoscopist after the needle is out? And I'll get to what I think the answer is, but you can also think about what the answer to this question is. Or maybe you don't have a role after the needle is out, you're done. We get a lot of outside cases at MD Anderson for second opinion. Patients are coming here. This is a noteworthy case we had a couple years ago. It was an EBUS case. Seeing these outside EBUS cases, I'm exposed to a very, very broad spectrum of clinical practice in bronchoscopy. This is one extreme. This was 72 slides that was basically, it was almost non-diagnostic. So this bronchoscopist might have thought, I've made 72 slides, I'm done, it's up to the pathologist. I would point out this bronchoscopist is doing a very thorough job. They made 12 slides on each of 6 passes, and they carefully put a big dollop of blood in the middle of every slide. They didn't actually bother to smear it. They just have the blood. And in fact, the blood is so thick it's hard to put a cover slip on it. But we may be able to get back to this slide. Well, actually, I should point out what this slide tells me is that this bronchoscopist is getting absolutely no help from their pathologist. I know that they don't have rows because no pathologist would subject themselves to 72 slides of this. And the pathologist would also suggest you might want to smear out this blood, and also ask why are you getting such a bloody sample. So let's move. You know, not everybody has the luxury of having access to rows. If we break up the procedure into steps, you know, the targeting is what the bronchoscopist does and determines, you know, gets the needle into the lesion. Acquisition is getting the lesion into the needle, and that's not always straightforward. And then the pathologist hopefully is able to take the sample and tell the bronchoscopist, yes, in fact, the lesion is in the needle, you're doing a great job, or no, this is non-diagnostic, you know, maybe you need to go for more. But the bronchoscopist also helps the pathologist stay on track. The bronchoscopist has to keep the pathologist focused on what the clinical question is to make sure that the sample is processed correctly, and that's the post-procedure workup. In the absence of rows, this still has to occur. There still has to be a communication in some form between the bronchoscopist and the pathologist. The communication has to go both ways. The bronchoscopist has to tell the pathologist, you know, look, here's what the issue is with this patient. And the pathologist has to communicate to the bronchoscopist, you know, you're giving me a very bloody sample with nothing in it. What's wrong with you? Or you're giving me a great sample. Keep doing what you're doing. So, you know, I'm going to speak very, very quickly about specimen acquisition, and this is really the one part of the talk that I'm basically going to leave alone. And if you're interested, you can go back and study it. Chances are you're already familiar with all of these variables, and you've already integrated them into your practice, and you're able to get, you know, highly cellular samples in a consistent fashion. In which case, you really don't need to review these. However, if you're at the beginning part of your practice, or you're struggling and you're not getting a lot of help from your pathologist, you have a pathologist who keeps telling you that you've got non-diagnostic samples, you might want to come back later and look at these variables. But I am going to. It is good to have a good sense of the significance of these variables, because this is what I'm going to skip to next. And these are all very much self-explanatory, so we're just going to skip ahead to these. To answer this question, what is the role of bronchoscopists after the needle is out? So number one is make sure the pathologist understands what the clinical question is. You know, most of the time you can assume that the pathologist is going to understand, but you know, it's kind of surprising how often we as pathologists just don't understand, or we get carried away by something interesting that is of no clinical significance. And you know, we have an unusual morphology, and we want to do 20 immunostains to study this weird tumor, and then we're going to, you know, maybe publish it or use it for a talk. But the real clinical question is, this patient has brain mets, and we need stuff for molecular testing. You know, so the pathologist needs to understand the clinical question and the context. And then the other important thing is what the bronchoscopist needs to do after the needle is out is evaluate your performance based on the sample or feedback from the pathologist. Now, I think ideally you'd have some mechanism where you can actually review slides yourself. You don't need to do this on every case. Maybe just the ones where you're having some technical difficulties. You know, once you get to a certain level of skill, there's much benefit to this, except for making sure that you keep a relationship going with the pathologist. But you need to have some type of feedback on your performance so that you can continue to get better. I personally have found that the people who want to get better at any type of needle aspiration, that they do, and that the people who aren't interested, they actually don't improve. And I can recognize the people who want to get better across a crowded room because I see them so often. even when they don't need to come and look at their cases. So putting together those 10 variables or 11 variables that I blew past very quickly, this is something that happens then after the needle is out, troubleshooting. And this is not so much to examine one particular case, but what is the habit of your cases. Excessive respiratory contamination. You know, I would think, and I have to freely admit, I am very spoiled working here at MD Anderson because I've got great bronchoscopists. I hardly ever see respiratory contamination. I mean, to be honest, if I do, it's just on one needle pass. But when I'm looking at outside cases, it's typical for me to see a lot of respiratory epithelium contamination. Now, this normally may not be such a problem, but it can make it very difficult when you're looking at well-differentiated adenocarcinoma and you have all of this contaminating respiratory epithelium. It makes it very, very difficult to know what is reactive versus neoplastic. So the causes of excessive respiratory contamination is improper use of stylet, is probably the biggest one. And the second biggest one would be excessive backstroke. So, you know, you're taking the needle all the way out of the lymph node and back into the bronchus and reinserting. But if you have the stylet in place and you are reasonable with your technique, you know, you should hardly have any respiratory contamination. This is probably the most common problem that I encounter on outside bronchoscopy cases is bloody hemodilute samples. Now, again, you can't judge a bronchoscopist based on one sample, but if it's the habit that your pathologist is complaining about how bloody and hemodilute the samples are, chances are you're misusing suction, or you're having issues with repositioning the needle between passes or even within the lesion. I've heard of some people who want to reposition bronchoscopy needles within the lymph node during a single pass, and that's really not feasible. And then another big cause is excessive dwell time, meaning that you're going after the lymph node for 20, 30 seconds. You know, the reality is you clear out the channel from your needle probably in about 10 seconds max. But you know, having the needle in for 30 seconds does not give you 3 times as much sample as in 10 seconds. It probably gives you about 10 times as much blood or more. So another problem is excessive clot. You know, that's also because you've got you're in the needle. The needle's in the lesion too long, and you're getting blood, and it's actually clotting in the needle. So of course, you're not collecting sample when you have clot in the needle. You're just putting holes in the node. And then another very common cause is slow team speed. You know, when you have a bronchoscopy team, everybody has to have their job and do it efficiently. If you have people who are not familiar with each other, or you don't do a lot of bronchoscopy, and so every time you're doing one, everyone's reinventing the wheel, you have a slow team speed. And so by the time you are able to get the sample out onto the slide, you've got a lot of clot. So, and then sparse cellularity in the absence of blood, in other words, a dry tap. This is really not that much of a problem for habitual results to have dry taps. But if you did, it's because your needle excursions are too short, and the FNA is, you're not doing the FNA long enough, or maybe you have insufficient suction. Of course, if you have fibrosis, those are also going to give you dry taps, and you can have dry taps because you haven't used the stylet properly, and the needle is plugged by cartilage. But that shouldn't be a habitual problem. Anyway, so this gets back to what the bronchoscopist needs to do after the needle is out is evaluate your technique or how things went on that particular case and what you might be able to do differently in the future. This is just to point out the diminishing returns. This is the pass number 1 often is the least bloody and most cellular. And if you can't reposition the needle well because it's a small node or a small access, typically the second pass gives you less tumor and more blood, and the third one will give you a lot more blood and less tumor. If you start out with pass number 3, your second pass will never be pass number 1 here in the pictures, unless you're able to really significantly reposition the needle. Now sometimes, this is as good as you can get pass number 3, and that's okay. We can work with a sample like this, but you always want to strive for having samples that look like pass number 1. And the other thing is, of course, the only variable that you cannot control in this is the nature of the lesion, and you really just have to adapt to it. And you can't approach every lesion the same way. You have to study it and then figure out what you're going to do. In this case, it's a case of metastatic renal cell carcinoma. Those are just enormously bloody samples, and you have to have a very, very short dwell time. And even under expert sampling, sometimes this is all you get is a lot of blood and a little bit of tumor. The opposite end is you've got older patients with sclerotic, gnarly lymph nodes that are basically like aspirating wood. You can be in there for 10, 15 seconds, and you need a lot of suction to be able to pull this material out. Typically on the smears, you get a lot of cell crush artifact, and on the cell blocks, you'll get a sample that's easier to review and analyze. So, and we always have to be aware of false negatives and false positives, but my personal opinion is that the most common denominator to false negatives and false positives is a sparse sample. So again, it's something that is a reason why bronchoscopists have to continually work to improve technique. So I didn't know where to put this slide in, so it's kind of just thrown into the middle. So reporting, I just wanted to point out that something that we do on our cytology reports is, we have the typical information, diagnosis and everything else, but we also put down in the bottom of all of our cytology path reports, if it's a malignant diagnosis, we have this box here which transmits information to the bronchoscopist, to the clinicians, to other pathologists, how good the sample is for molecular testing or for immunostains. So this is, for instance, cell block. If you have less than 50, that means you could use immunostain, and you could maybe do FISH, but you can't do PCR-based studies. The cellularity is too low. We basically have 3 categories: low cellularity, medium cellularity, and high. This is the number of smears that would be suitable for MDL testing, molecular testing, the number of diff-quick stain smears that would be suitable, and the number of diff-quick stains that would be suitable for FISH. We do a lot of FISH testing here. Anyway, it's something to think about if for your pathologist, if this would be helpful to you guys, to talk it over with your pathologist to see if they could put information like this in their path report. We use this every day because we have a lot of tests for ancillary, a lot of requests for ancillary testing, and so we refer to these often. Okay, processing and handling. So this is after the needle, but again, this is where you are critically important to make sure that the sample is processed appropriately, because that's going to depend on what the clinical question is. Obviously, you're going to process a lymphoma different from an infection versus something that's needed for PCR studies, and so the processing depends entirely on what you think needs to be done with the sample. So case in point, this is a patient who has a history of lung cancer. It's a very good lymph node aspiration, and it'd be very easy to, and not incorrect, by the way, to say no metastatic melanoma identified, cellular evidence of lymph node sampling. But the bronchoscopist in this point intervened and said, you know, I'm more concerned about lymphoma based on the way this looks. So we were able to collect for an RPMI and send for flow cytometry, and sure enough, it was a low-grade follicular lymphoma. So basically, anything that can be done on a core biopsy can be done on an FNA, almost anything. We don't do karyotyping and electron microscopy hardly at all anymore, but everything else we do regularly. I'm going to show two special tricks that we use in our cytology lab, and this is something that you could share with your pathologist if you feel like it would be helpful if you're ever in this situation. One is called a pick-lock technique, and the other is called a cell transfer. So I'm going to skip this slide, but this slide you can come back to. But you know, even which slide you use depends on what you think the clinical question is and what you're going to need the FNA for. Because so many of our EBUS cases end up for molecular testing, we never use this frosted slide. But anyway, you can go back to it. The other thing, in terms of after the needle, something that's greatly underappreciated is how important smear technique is. Smear technique is not rocket science. It's just some basic hand skills, but it's extremely important to have good, well-prepared smears. I'm going to skip this, but you can come back to it. Also, so specimen processing, do you make smears or do you make cell blocks? This is really going to be driven by your pathologist, and it's going to be also driven to a large extent by the capabilities of your molecular lab. You know, if your molecular lab doesn't handle smears, then you really need to be cell block intensive. And that's going to change how you approach making how you do your FNAs, how much you put on smears and how you put on cell blocks. This really needs to be guided by the pathologist. You know, cell blocks are great, but adequacy really is not guaranteed, as it is with smears. But everything is standardized to cell blocks, you know, immunos, FISH, and PCR testing. The one advantage that smears has is that PCR testing is better on smears in cases of low tumor fraction, and I'll show you an example of that. So this is, I was going to show you a pick-off technique. This is a patient with Burkitt leukemia lymphoma, but PET scans show some adenopathy. And at immediate assessment, this is called non-diagnostic. A lot of blood clot and some little fragments of cell crush artifact. On careful review, there's a couple small fragments that look like fibrosis, and I would be inclined to just call it fibrosis. But because this is otherwise non-diagnostic, you can literally just take some tweezers and pick the tissue off of the slide and embed it in paraffin and take sections of it. And in this case, it saves the diagnosis here, and this is probably a lymphocyte-depleted lymph node, a lot of histiocytes, which would account for the PET positivity. What we do more often, though, is called cell transfer technique. And that's a method by which you take one smear and you cut up the smear and make multiple smears that you can do immunostains or FISH or PCR on it. This is a case in point. This is a woman who presented with brain metastasis. The EBUS was the only tissue that this patient had. Now, this bronchoscopist went to 8 passes on this patient, and everything was necrotic except one of the 8 passes had viable tumor on it. So we can take this slide and basically put mounting media over the decover slip slide, let it harden, and then pull it off and then cut it into pieces. And then this is what it looks like. Here's the original slide, and then here are the 14 slides that are made from it. So from this one slide, then, we can do immunostains. This is a photograph after the cell transfer. You can see how good the morphology is maintained. And we're able to do a TTF1, which shows diffuse positivity, and it was negative for napsin A and also for the neuroendocrine markers. So it's called adenocarcinoma. Now, because we were able to preserve the sample as much as possible, 5 months later we get a request for FISH and also for PCR studies. So we're able to send for ALK, and we're able to send for NGS testing, which showed RB1 and P53 mutations. So, and we still had sample left over, and that was just from one slide. So sometimes it's good to have this in your back pocket in case it's needed. So let's talk about biomarkers, basically immunostains, FISH, and molecular testing. The immunostains, this is the 2 immunostain profile that basically everybody uses, and it's to give the best classification with the least amount of immunostaining so that you're not wasting sample that might be needed for molecular testing. So some people use P63, that's an older marker, instead of the P40. But basically, if P40 is positive, it's squamous cell carcinoma. If there are very rare cases where you have P40 positive and TTF1 positive, but under those circumstances, it's usually TTF1 is diffuse and P40 is focal. That's still called adenocarcinoma. If they're both negative, it's probably an adenocarcinoma, but we'll call it non-small cell, but it's a non-squamous non-small cell. And then there's also the possibility that it's metastatic tumor if it's in this quadrant. So this is the P40 TTF1 is something that we use on probably 80% of our cases. If something is clearly keratinized, we'll call it squamous, or if it's clearly gland forming or mucinous, we'll call it adeno. But a lot of cases are in between. I've shown this slide to a lot of pathologists. Probably about 60% said they would call it a poorly differentiated adenocarcinoma. But here's the cell block from the same case, and the cell block, the P40 shows, or this was P63 was used, shows that this is a squamous cell carcinoma. I'm going to give a brief word about PD-L1 because we're starting to use it a lot. We started doing the immunostains on our cell blocks a little bit over a year ago, and basically we were yielding to clinician pressure. Basically, they insisted on it, and it turned out that a lot of other centers were doing PD-L1 testing on cell blocks, even though, if you read literature and stuff, people say that it's supposed to only be done on core biopsies. So we went through validation steps to show that we had similar results on cell blocks as on cores. Here's tumor here showing strong positivity. Here's normal bronchial epithelium showing negative. These are difficult to interpret sometimes, but the ones that are strongly positive are usually very easy. This is a case that's of interest because this is the FNA cell block. This is the cord needle biopsy. This was not my case. This is clearly a squamous cell carcinoma. I don't know what possessed the cytopathologist to do P40 and TTF1, but the TTF1 is strongly positive and the P40 is negative. So even though it looks like a squamous cell carcinoma, it's an adenocarcinoma. This core biopsy was signed out by a famous thoracic pathologist as squamous cell carcinoma. After the discrepancy was brought to his attention, then he repeated the immunostains that also showed TTF1 positivity. What's interesting is that this was one of the first cases of PD-L1 that I had. The request came to me for the PD-L1 testing, and so I did it. I reported it out as, I think, 10% or 15%. You can see the positivity here. Well, the surgical pathologist didn't know that I'd done it on the cell block and did it on the core biopsy and reported it out as 0%. So I don't think this is 0%. To be honest, at low power, it looks like 0%, but if you go at high power, it's more in line with what the cell block shows. So this made me think that the discrepancy sometimes that you may see between PD-L1 testing may be observer dependent. Anyway, to me, this shows great fidelity across substrates for the PD-L1 testing. And as I said, the ones that are really strongly positive, I mean, they're really obvious at low power. You don't have to, work too hard. But all of these require validation, especially ones that are treatment-centered, like PD-L1. Also, BRAF. We've validated BRAF. It works fine on cell blocks as well as on core biopsies. But we don't do PD-L1 or BRAF testing on smears because we've tried the validation. It just doesn't work in our hands. So let's talk about FISH testing. We've been doing FISH off of diff-quick stain smears for over 20 years here. It was started by Dr. Noor Sneej, who's a famous breast pathologist, and for HER2/neu. Basically, any FISH test that can be done on a diff-quick stain smear. Here is a case. This is almost a throwaway slide. There's hardly any material on it, but it has a little bit of tumor, so we keep these rather than throwing them out. And here is this area here. This is the tumor. This is this very same case. This is the cell block. And look at how much bigger the tumor is on the diff-quick stain smear than it is on the cell block. And also, these are easier to interpret on the smears is because there's less contaminating mesenchymal elements. When you get this under a fluorescent microscope and you're looking at these cells are very easy. They stand out. Imagine trying to interpret a FISH on this cell block, trying to pick out this nucleus versus these other nuclei. There's a lot more room for error, human error, on testing on a cell block than there is on here. Plus, because the nuclei are so much bigger, it's a lot easier to see the signals on the break-apart probes on FISH. Mike Rowe, who's now up at Mayo in Rochester, has an interesting paper from 2013 which shows a high concordance between ALK testing on smears versus cell block, and there was actually one discordance, and it was positive on the smear, negative on the cell block, and that has to do with the number of the distance between the break-apart probes is easier to see on the smear. And like I said, any FISH test that can be done on a smear. This is a case that came in as a sarcomatoid mesothelioma, and our thoracic surgical pathologist said he didn't think it was. He thought it was a synovial sarcoma, so he submitted histologic sections for FISH, and guess what? It didn't work. Just because you have paraffin tissue doesn't mean that you're going to get a result. Sometimes there's things that inhibit with the signals and whatnot. So fortunately, there was an EBUS that had been done, and we were able to submit for FISH testing, and the FISH showed the SS18 was positive on the break-apart probes. So, okay, I'm going to have to go a little bit more quickly. You're familiar with driver mutations and how they're usually mutually exclusive. At our institution, we have, if there's just a single gene that's tested, EGFR for instance, it'll go for Sanger sequencing. But if two or more genes are requested for mutational analysis, then it'll go automatically to an NGS platform. And we have a number of NGS platforms available. But it's important to know what the tissue requirements are in terms of total DNA input and tumor fraction. So these are various platforms that we have available at our institution. Generally, 20% is the lowest tumor fraction that we can have. So I'm not going to ask for input, but just this is to help you know how much material that you need to acquire, how many cells are needed for 1 nanogram of DNA. So for instance, notice that the total DNA input here that's required is, so for the 50 gene panel, it's 10 nanograms. How much do you need? And actually, by the way, now we have this down to 2 nanograms. How many tumor cells are you talking about? Well, it turns out that the answer to this is 1,000. 1,000 cells equals about 1 nanogram. So if you need to have 2 nanograms, you only need 2,000 cells. So when we're looking at these smears or cell block sections in the pathology for pre-analytical assessment for molecular testing, we have to judge the purity. We want to have sufficiently pure samples so that we don't have to worry about a false negative, but we have to also submit enough cells so that they're able to get a signal from the NGS testing or the Sanger or whatever. So we always want to be in this quadrant where we have high cellularity and high tumor fraction. We never want to send anything below the analytical threshold of tumor fraction, because then you're going to have a false negative, and nobody will ever know that it's a false negative. These thresholds differ depending on what method is being used. Sanger sequencing is much higher than next generation sequencing. Some require more cellularity than other cellularity. So we really need to know what tests are available before we can assess. Now, you take 2 bronchoscopists. Bronchoscopist A routinely gives very high cellular sample. That makes it a lot easier to do tumor mapping, because with tumor mapping, we mark areas of the slides of relative tumor enrichment. We're decreasing the amount of cells that we're sending to the lab, but we're increasing the tumor fraction, but we're still up in this quadrant. So we have a lot of confidence that we'll have a result, and that result will not be a false negative. Another bronchoscopist whose technique is not as good routinely gives samples which are, reasonably cellular but not great. It makes it much, much more difficult to do tumor mapping, because you decrease the amount of sample that you're sending to the lab, you're increasing the tumor fraction, but your cellularity may be below the analytical threshold. And tumor mapping is not hard. It's tedious, but it's not hard. So here's you have this dot here on this slide. This is 1,000 cells. This is 1 nanogram, and this is pure tumor here. This fuzzy area here, this is a lot of lymphocytes, 20% tumor fraction, 5,000 cells. You wouldn't want to send this for Sanger sequencing, but you could use this in combination with the others to submit for NGS. So the other variable is cellularity, is tumor fraction, yeah. So this is another one that I show. The typical answer that I get when I show this slide is that the tumor fraction here is 40 to 50%. In fact, this was submitted as 50%. But for someone who looks at these pre-analytical evaluations a lot, one can easily recognize that this will be a false negative. And in fact, this was submitted for EGFR and it came back as negative. But I knew that just by looking at this. The real tumor fraction here is 15%. And what we do in Path Lab is, we should use a graticule and kind of do some critical counting, especially at low tumor fractions. But the rule of thumb for me is I estimate what the area is occupied by tumor and the area that's occupied by lymphocytes. I take that ratio. In this case, let's say that you come up with 40 to 50%, and then I divide by 3, because you can fit a lot more lymphocytes into the same space that you can fit into an area of a tumor. So I'll divide by 3, or sometimes even by 4 if I've got very large tumor cells. And that'll give you an answer that's very, very close. In this case, the tumor, if I do a more critical counting, I get like 15%, which is below the analytical thresholds for anything that we have. So I'm going to skip over this. So this is very similar. Here you can say this area is tumor, this is lymphocytes. We've got 1, 2, 3, 4, 5 areas of tumor. We have 1, 2, 3, 4, maybe 5 areas of lymphocytes. The tumor fraction here is also probably about 15%. Anyway, this is good for you to know as bronchoscopists, because you can quickly check how good your pathologist is. Look at a case over the microscope and ask them what do you think the tumor fraction here is? If it's a similar case and they say 50%, this is a good sample, and you look at it and you know that you need to divide by 3, then you have to start wondering about all those negative PCR results that you've had lately. So a lot of our cases don't require any tumor fraction, any tumor mapping. You know, they're highly cellular. You know, it's nodal replacement by tumor, and you know, it's very easy. Many of our cases require very, very little tumor mapping. But you know, when the tumor is very cohesive, like this case, it's very easy to isolate this from all of the background lymphocytes. I mean, you could literally just take a toothpick and just pick this off. And so this dot here, that's 1,000 cells, that's an nanogram. You're already halfway to an NGS. And this is more intensive, and this is a more difficult and time-consuming type of tumor mapping. A case like this might take me 30 minutes to do. But at least I can send and know for sure that my tumor fraction is high enough. I may not get a result. It may be non-diagnostic, but I don't have to worry about a false negative. And then there are some cases, especially when the tumor is discohesive. And in our EBUS cases, and we have a lot of lymphocytes and it's partial nodal involvement, tumor fraction is too low. You just cannot do the NGS, and you shouldn't try. And even in some of our cases, you know, when the tumor fraction is too low, sometimes you can go along the feathered edge of the smear and find areas of tumor enrichment. And this is what it looks like after. This is an intensive tumor mapping. You know, the overall tumor fraction of these smears is under 1% easily, but they're little cohesive fragments. Here you can see also these are little flecks of tumor, but there's so many lymphocytes I couldn't get a circle around it with confidence. I'm going to skip this. You can look at this later, but this is a study that we did that showed informative results, and FNA was, as good or better in FNAs than in core needle biopsies, and with the same level of detection of EGFR and KRAS. And this is just to point out, some people are very pro core biopsy, and frankly, I am too. I'm all for getting as much sample from as many modalities as possible, because core biopsy and FNA are complementary. But core biopsy suffers from an inherently lower tumor fraction. FNA does not sample all of these mesenchymal LMs. These just don't come out very well from the needle. What comes out from the needle, and this is a percutaneous lung FNA, is these little clusters of tumor. They come out on the FNA, but all of the cells from in between, the woody portion of the tumor, don't come out. So you start out with an inherently higher tumor fraction, and actually, you also start out oftentimes with a higher number of tumor cells too. But I know that people are moving toward doing core biopsies on bronchoscopic cases, and I think that's great. But I think FNA should be is your first best hope for getting a good sample for PCR studies. And this is a study, you can look it up, but it basically shows what we thought is that there's an inherently higher tumor fraction with FNA than core biopsy. So essential variables of bronchoscopy sphere of influence. The nature of the lesion is what it is, and you have to adapt to it. The bronchoscopist, the only thing you have control is over yourself. If you're lucky, you have control over your team. If you're very lucky, you have a pathologist who is agreeable to work with. Flattery and food bribes usually work, but sometimes, unfortunately, I know that I'm in a field with a lot of how shall I say, quirky personalities, and who may not know how to play well with others. But most of us are try hard. And then the pathology molecular labs. This is the one that you have the least influence, and even the pathologist often doesn't have much influence. But I think smears are really the way to go. But if all that they can do is cell blocks, then you have to work with that. I think that this is the last slide that I have. So if we have any questions, I'll be happy to take them.
Perfect. Thank you, Dr. Stewart, for really providing an excellent and comprehensive insight into the importance of the bronchoscopist-pathologist relationship and the importance of mutual feedback needed to maximize our practice. Of course, this is especially vital in today's rapidly evolving climate of the diagnosis and management of thoracic malignancy. So as we're awaiting for a couple additional questions to come in for the audience, I'll get one or two started here. So one of the final frontiers EBUS TBNA has yet to conquer, I think, in terms of diagnostic prowess is lymphoma. As representatives of or one of the largest and most renowned cancer centers in the world, I'm interested to hear your insight into how you've optimized your approach to the diagnosis of intrathoracic lymphoma using EBUS. Dr. Stewart, perhaps you can go first, and then we can get additional pulmonologist perspective from Dr. Casal.
Sure. Well, from a practical point of view, all that we require in cytopathology is, if that's the clinical suspicion, to let us know, and then the bronchoscopist does needle rinse into RPMI. We do a cell count on a culture counter to make sure that we have enough cells, and then we'll send that material off to flow cytometry, and we'll also make a cell block in case we need immunostains. However, there are some people object and say, you can't make diagnoses of lymphoma based on FNA. That's true, and it's also not true. You can certainly, I think you can do a very good job with about 80% of the lymphomas. But it's a moving target. Hematopathology is an evolving field. I swear every time I turn around, they've got another type of lymphoma that they've identified. It's hard to get to that level of granularity on an FNA. But you can, most of these are B-cell lymphomas. And you can certainly identify that it's a CD10 population, and that it's a follicular lymphoma. You don't have large lymphocytes, so it's a low-grade follicular lymphoma. You can say it's a Burkitt lymphoma. You can basically triage it into a good enough category that the patient can be referred to a hemato-oncologist, which is really what the next step is. And then they have to decide, are there other lymph nodes? Do we need to get an open biopsy? Is there something that can be cored? So I think that the role for the bronchoscopy under this circumstance is just to document that there's a lymphoproliferative disorder that requires appropriate consultation.
Excellent, thank you. Dr. Casal, any additional thoughts?
Yeah, well, I echo John's words, and I think that the most important part is our interaction, for all the cases, but particularly also for lymphoma, the pathologist. Sometimes it is a relapsed lymphoma, and it's very important that we tell them, what kind of lymphoma the patient had from before. Then the technique, John just explained what we do here at MD Anderson, but I think that the feedback from Rose, if you have it available, it's very important to know, how cellular, our samples are, and that's going to determine, how many passes we're going to take on these patients. We do have the culture analysis, and we get the feedback with the number of lymphocytes that we're getting, and I think that's key.
Dr. Stewart, you mentioned, real quick follow-up, you mentioned that you perform a cell count. Is that just to understand the practical nature of that a little bit, is that done at the bedside, or do you collect it into RPMI or some other media and have the cell count done in the pathology lab?
Yeah, so that's done from the RPMI. So we take I don't know what the volume is, but it's like probably 50 microliters. So we take a drop out, and then we just put it into the culture counter, and that gives us a cell count that's reasonably accurate. Most of our EBUS FNAs that we get for lymphoma, we collect in 10 milliliters of media, and we have cell counts that are over 1 million lymphocytes per milliliter. So normally there's over 10 million cells. For perspective, for flow cytometry, really we only need about 2 million cells for a full B-cell panel.
And we do it during the procedure, and typically speaking, it takes about 10 minutes, to get the call back, from the pathology lab with the count, not more than that.
Perfect, thank you. We have a question here about the bedside processing, smear versus sending an embedded formalin for cell block. Are there advantages and disadvantages of each in general, or perhaps for select situations?
Well, so the advantage of doing smears is it allows for immediate assessment. And the other advantage of smears is that it'll improve your ability to do mutational analysis, assuming that your molecular lab will handle smears. The difficulty with relying totally on cell blocks is that you're not guaranteed to have adequate material. And cases of inherent low tumor fraction, you won't be able to do PCR studies as easily.
Yeah. And I've seen it, a few times, that you actually, we do smears and also put some material on the cell block. And the material that you put on the cell block sometimes is just blood clot. And you're thinking that you're adding more, and then when you get the report, the slides, are cellular, or they can provide a diagnosis, but the cell block actually doesn't support much diagnosis because it doesn't have much. So what you put in the cell block, if you don't have any on-site evaluation, many times, it's not what you think you're putting in. It's just a clot that looks like a core or something, but it's really clot, blood clot.
Now I'm curious. Do you have an on-site? Do you utilize an on-site cytotechnologist for your rows, or is a pathologist always involved, or do they just come in as needed?
We have cytotechnologists. So our senior cytotechnologists. So cytotechnologists who've been in practice for say 3 years, they're more than capable of doing rose immediate assessments. They handle all of the roses. If there's any question, they bring it down. I honestly, we have over 2,000 EBUS cases a year. I have maybe a question on about 5 cases a year that they show me. We have other people on our staff, but I get maybe 5 questions, and 4 of them, the cytotechnologist is right on. She just needs to have a little bit of assistance. And on the 5th one, I have no idea either. So they're, yeah.
And actually, we have looked at our concordance rate, between Rose and the final pathology, and Rose is only done by cytotechnologists, and it's pretty high. It's more than 90%. So we truly, trust our cytotechnologists.
Thank you. That's excellent information. We have one final question here. This individual is referring to your example that you brought up earlier in the talk, Dr. Stewart, about the 8 passes that were negative except for 1 that was positive for malignancy. The question is, how common is it that you see that, and is there utility in doing more passes?
Well, so actually there's 2 points here. One is on that particular case, all of the passes were necrotic, like totally, utterly necrotic tumor. So nothing that you could even identify as being, you know that it's tumor, but you can't tell what type of tumor it is. You can't tell whether it's melanoma or lymphoma or carcinoma. There's only one of the 8 passes was viable tumor. And that's not uncommon, especially when you think about the squamous cell carcinomas and the necrosis. So it's not uncommon that typically our bronchoscopists do 5 passes per lymph nodes. A couple do like 3 passes. But it's not uncommon that only on one of the passes do you have viable tumor and the others you have necrotic. We also have, much more uncommon, but we also have cases where there's 5 needle passes and they're all cellular, and on one of them there's tumor. That's, it's a low rate, but it might be like 2% or 1% of cases.
Excellent, thank you. One final question here. It asks, if we are trying to do a retrospective quality assessment with our pathologists on the quality of our EBUS samples, what are the few recommended outcomes that you have we should aim to review?
Well, obviously the first one would be your non-diagnostic rate. but that's going to have to be determined. And you know, another you could do is how adequate is, if it's tumor, how adequate is it for, you know, immunostains and complete workup. I would look at the extremes would probably be the easiest. I don't know, Roberto.
Yeah, so I would think, you know, like diagnostic adequacy. I mean, adequacy of the sample. Adequacy, we're not talking about the sample being diagnostic, but for example, having lymphoid tissue, right, and adequate amount of lymphoid tissue. So that's very important. I mean, to know how often it is inadequate, actually. And then if it's diagnostic of lung cancer, how often, for example, you have enough, you know, to typify the histology, like John was saying, you know, to do immunohistochemistry, and then also look at how often do you get adequate samples for molecular testing. So those are the things, you know, that will give you good feedback and see if there's that you need to change, either you or your pathologist or the molecular lab. And I think that what comes out of this great lecture that John gave is that the interaction, the more you interact with your pathologist, the higher your yield is going to be. I can tell you that, you know, and I didn't always work here. I worked for 6.5 years at the VA hospital, which is a very different environment. And I had really absolutely great yield. But the main thing is, you know, we did have on-site, I told you, but we interacted, you know, and I reviewed all the, most of the samples during the entire 6 years. It's not that I needed to, but I mean, first of all, you know, you learn quite a bit. You know, you learn from each other. You learn from the pathologists learn from you, and the only one who benefits out of that is the patient. You know, so it's time well spent. You know, if you have the ability to do that, you know, it's really time well spent, and that's going to increase your yield. The more you interact with your pathologist, the better your yield will be. I can guarantee you that.
Yeah, and the more you work with your pathologist, the better your pathologist will be. You know? I mean, it's true. So, and also the more sensitive your pathologist will be to what your actual needs are. You know, and by extension, what's in the best interest of the patient.
Absolutely. Thank you, Dr. Stewart and Dr. Casal for excellent insight there. Again, one of the key points I've gleaned from this talk is truly the importance of the relationship between the bronchoscopist and pathologist. I think we're about out of time. We'll take the last minute or two for any final questions that may come in. And in the meantime, I'm going to turn it back over to Dr. Shah for our closing comments.
Great, thank you. And again, I would also like to echo Ara's appreciation of our two speakers today for giving us a wonderful talk and a comprehensive look at both sides of what we do with an EBUS needle and the specimens that it contains. While we're waiting, I want to alert the audience. You probably have seen announcements for this, but the inaugural AABIP conference will be held in Denver, Colorado. We are very excited to have this or launch this first conference, which will be held on August 23rd to 25th. You should be receiving emails about registration information and further details about the conference upcoming in the next couple of weeks. So please keep an eye out for that. And then the second thing is that our next webinar will be planned for June 6th. So look for your email announcements about that. That will be on the topic of cryoablation for central airway obstructions, and our speaker will be Ashutosh Sachdeva from the University of Maryland, and as I mentioned, that'll be on June 6, 2018. So keep an eye out for that. So thank you very much, everyone, for joining us today, and with that, we'll go ahead and close this session. Thank you.